for the next session, our speaker is Puan Nurul Akmahanan, a U52 pharmacist at Hospital Tuanku Jaafar. She obtained her master degree in health psychology from USM in 2017. Her experience as a pharmacist is more than 10 years. She also a member of Malaysian Pharmaceutical Pharmacy. Without further ado, I would like to invite Puan Nurul Akmal to deliver her topic entitled Drug Usage in COVID-19 Cases and Interaction with Nutrition.
Assalamualaikum warahmatullahi wabarakatuh and a very good morning. Thank you, Ms. MC, for the kind introduction. I'm honored to be invited today to deliver a topic on drugs in COVID-19 cases and drug and nutrition interaction. So without further ado, let me share my slides. Content will be covering on the overview of COVID-19 and then COVID-19 interventions, drug use in COVID-19, COVID-19 drug nutrition interaction, and how do we tackle this interaction. Second last, significance of screening for interaction and take-home messages. COVID-19 is caused by SARS-CoV, the coronavirus which emerged firstly found in Wuhan in December 2019. Later on, the endemic becomes pandemic globally. This COVID-19 can be mild to healthy patients, but it can be severe and cause millions of deaths globally, as well as lasting health problems among those who have survived the illness. This is especially for patients who have comorbids. COVID-19 can be divided into 5 categories. Category 1, those patients who are infected but no symptoms. Category 2, those with have mild symptoms such as fever, GI losses, nausea, vomiting, diarrhea. Special characteristics, patient with anosmia, loss of sense of smell, ageusia, lost sense of taste. Then patient may also have cough. Then patient in a moderate COVID-19 category 3, patient have these symptoms and also pneumonia. The pneumonia can be checked via lungs auscultation and also through confirmed with a chest radiograph. For patients who infected with category 4, on top of all these mentioned symptoms, patient also have pneumonia and also requiring oxygen, whereby patient have shortness of breath. Now, the supplemental oxygen may ranges between the low setting oxygen, medium setting up to high setting oxygen, such as the high flow nasal cannula. While in critically ill COVID-19 category 5 patient, not just have those above mentioned symptoms and also requiring oxygen, but they have multi-organ failures. The respiratory failure, patient requires ventilation. Other than that, patient may have acute kidney injury and or acute liver injury. Now let's look at the overview of COVID-19 progression and interventions. This is a severity and clinical manifestation as the category 1 upgraded into category 5, patients becomes more severe. Then the pathophysiology, whereby during the initial phase, patients may have tissue damage where the nasal, respiratory epithelium, and alveoli and vessel endothelium will be affected from the interaction between the virus on the host cells. After the viral replicates and then forming host response, the organs becomes damaged, involving from the lungs initially and eventually if multi-organ is involved, the heart, the kidney may becomes affected, becoming multiple organ dysfunction. Now, the interventions and treatments is targeted according to the pathophysiology, which will be described later on. Okay, depending on the pathophysiology, which is come up with the intervention treatment objectives. Firstly, to stop, reduce, and inhibit viral replications. This is especially during the initial phase of the disease. And then secondly, to suppress the inflammation response. So third, to prevent the disease complications. The disease complications includes coagulopathy and then peptic ulcer bleeding, and then patient are recovering from after the intubation from the muscle paralysis. Okay, and lastly, to treat disease complications if complications develop. The COVID-19 interventions, there's 4 main interventions, which includes the pandemic control and prevention. Secondly, symptomatic treatment. Thirdly, prophylactic or preventive treatment of the complications, because we anticipate that the COVID-19 will bring a lot of complications. Therefore, we give preventive treatment before the complications develop. But if complications develop, then we will give the complications treatment. Okay, pandemic control includes wearing masks, properly covering the mouth and also the nose, not under the mouth, not under the nose. And then frequent hand hygiene, especially the 5-moment hand hygiene before and after touching patients or person, and then before and after exposure to bodily fluid. And lastly, the 5th hand hygiene moments after exposure of a patient or person's surrounding. Hand hygiene can be done with either soap and water or alcohol-based hand rub. And then thirdly, social distancing and also vaccination, as our country is on the move to fasten up in gaining herd immunity. Okay, symptomatic treatment may comprise of antipyretic for fever, and then fluid and electrolyte replenishment if patient is having GI losses, diarrhea, vomiting. If a patient have poor oral intake, try to encourage patient to replenish the fluid and electrolytes. Antivirals for the COVID-19, antimicrobials, anti-inflammatory, and or immunomodulator. Convalescent plasma is not part of the pharmaceutical. This is from the blood bank. Okay, as for prophylactic treatment for possible complications, may include physiotherapy against venous thromboembolism as one of the complications, to encourage the ambulation, especially patients in category 3. However, anticoagulant can be given against VTE for high-risk patients, those in category 3, 4, and especially in category 5. The gastroprotectants against peptic ulcer bleeding for high-risk patients, especially patients in category 5. If complications occur, then treatment for the complication is given. That is oxygen therapy for hypoxia for those patients in category 4 and 5, and antimicrobials for bacterial infections, anti-inflammatory agent, and as well as anticoagulant for VTE, and also ventilation support for patients who have respiratory failure. Okay, the treatment of complications also include blood products if severe bleeding occurs secondary to the anticoagulant given. Then so if patient is having acute kidney injury, then renal replacement therapy, which conclude either CVVH, SLAT, or hemodialysis. And then enteral or parenteral nutrition. And lastly, physiotherapy. This is especially true for patients recovering from COVID-19 to encourage ambulation and also incentive spirometry to improve the patient's lung function. Okay, drugs used in COVID-19 cases, the majority of drugs used in COVID-19 were similar to those in SARS or MERS, because antivirals, when even in COVID-19, it offers a few advantages such as reduce the viral loads, reduce the infectiousness of virus in patient respiratory secretion. Because during the initial phase of the COVID-19 infection, one patient having symptoms, the viral will increases and peaks up to 5 to 6 days after the onset of the symptoms, while virus shedding occurs from day 0 until day 14. This will results in more the COVID-19 becomes contagious towards other person. Yeah. Okay. Other than that, the antiviral drugs may help in shortens the treatment duration as well as improving the prognosis, especially when these antiviral are administered timely. Timely means at the appropriate stage of the COVID-19 disease. Previously, chloroquine, hydroxychloroquine, and also lopinavir plus ritonavir has been used in COVID-19. However, these drugs are no longer used as the IDSA, Infectious Disease Society of America, and the National Institute of Health NIH COVID-19 treatment panels recommends against using these agents to treat COVID-19. Previously, we do use these drugs even in our healthcare facilities, but since the outcomes of these patients are there's no positive outcomes. Therefore, this treatment has been abandoned. Additionally, there is insufficient evidence for the both panels to recommend either to use or not to use ivermectin for the treatment of COVID-19 unless the use of ivermectin is in the context of clinical trial. Regarding the use of favipiravir, its role has been described in several studies. Early trials in the Russia and also China suggested that favipiravir produced some benefits. However, since the study, the use of favipiravir is also to get in conjunction with other therapies such as the immunomodulatory agents. Therefore, the results of these studies have to be interpreted with caution because of the confounding factors. Another trial in Iran suggested there is no benefit for favipiravir for severe COVID-19, category 4 and category 5, which is why in Malaysia per se, favipiravir is used in patients in category 2 and or category 3, but not in category 4 and 5. Okay. And then IDSA and the National Institute Health NIH COVID-19 treatment panels also recommends the use of remdesivir, another antiviral, in patients who requires oxygen therapy, category 4. Moving on to the antimicrobials, basically antimicrobials is not required in COVID-19 because remember, COVID-19, coronavirus disease, it is of viral origin, not bacterial. However, antimicrobials may be given to patient who is co-infected with bacterial infection, or if patient have any secondary bacterial infection, meaning patient have the COVID-19 itself first, and then after sometimes in the hospital, patient acquired a new infection, most probably bacterial. And then the choices of antimicrobial will depends whether it is community acquired or hospital acquired, following the national or local antibiotic guideline. Or if antibiogram is available, then the facilities may refer to the antibiogram. Example of community acquired antimicrobials includes amoxicillin clavulanate or its other trade name augmentin, and or patient may be given with ampicillin sulbactam known as unacin or other antibiotic and zithromycin. If the infection, bacterial infection, is suspected from hospital acquired, then antimicrobial piperacillin tazobactam or its other name tazocin or other group meropenem or vancomycin may as well be given in the patient. However, any empiric therapy, empiric means treatment without knowing the actual organism causing the infection, it should be rapidly de-escalated according to the actual growth based on the blood CNS, tracheal CNS, urine CNS, or etc. And or the empiric antibiotic therapy should be discontinued if there is no evidence of bacterial infection. This is important because we want to preserve antimicrobials and to prevent resistance towards antimicrobials. Moving on to anti-inflammatory use in COVID-19, acetaminophen or its other name paracetamol, or in Malaysia we widely know as Panadol, is actually the preferred antipyretic if fever is present. Non-steroidal anti-inflammatory drugs has also been used in positive COVID-19. There's a study called ISARIC Clinical Characterization Protocol UK, which studies the outcome of NSAID use among positive COVID patients. Then the study showed that no increase of risk of poorer outcomes. Outcomes was measured in terms of mortality as the primary outcomes and secondary outcome as the severity upon admission into the hospital or any admission into the ICU, receipt of oxygen, receipt of ventilation, as well as the incidence of acute kidney injury. All these primary outcomes and secondary outcomes was measured that there is no increase of risk poorer outcomes among the positive COVID-19. The study assets include the ibuprofen, diclofenac, naproxen, meloxicam, and celecoxib. Now, NSAIDs have analgesics. Analgesics means pain medication and anti-inflammatory effect, which is helpful in mild COVID-19, category 2 and category 3. And additionally, ibuprofen also has antipyretic effect as well. If patient is allergic to the paracetamol or paracetamol is not reducing the fever, patient may change to ibuprofen. Now, if NSAID is needed, lowest effective dose is advised. This is to minimize the common adverse effects, especially the gastrointestinal upsets. Okay, as for besides the NSAIDs, the mainstay of the COVID-19 treatments includes corticosteroid, which is dexamethasone. It is recommended in severe COVID-19 category 4 and category 5 who are on supplemental oxygen or on ventilator support. Now, if dexamethasone is unavailable, other glucocorticoids can be used, such as hydrocortisone, methylprednisolone, or prednisolone. However, these glucocorticoids can be used at equivalent doses, although data supporting the use of these alternatives are limited as compared to dexamethasone. In contrast, dexamethasone or other glucocorticoids is not to be used either for the prevention or treatment in mild to moderate COVID-19, meaning it shouldn't be used in COVID-19 category 1, category 2, and category 3. Okay, moving on to the immunomodulator used in COVID-19. So the examples include interleukin inhibitors such as the sarilumab and tocilizumab, which are the recombinant humanized monoclonal antibody with the ability to inhibit interleukin 6 receptor, which is involved in the inflammation response. The result of the recovery trial and also REMAP-CAP provide consistent evidence that tocilizumab, when it is used together with corticosteroid, in the study, the used corticosteroid is dexamethasone. This combination offers a modest mortality benefit in COVID-19 patients with cytokine storm. Now, cytokine storm is when patient becomes severely ill, rapidly deteriorating with increasing oxygen needs from the nasal prong towards the high flow mask, towards nasal cannula, and then eventually will be needing the ventilator support. Patient have significant inflammatory response. The inflammatory markers check is the CRP. And then if patient having all these signs, patient is in the cytokine storm. The tocilizumab combined with dexamethasone proven to provide modest mortality benefit. In other studies and subgroup analysis of patients requiring low support oxygen, category 4, the covariate trial showed that addition of baricitinib and dexamethasone resulted in lower mortality compared to those who received placebo. However, this difference was not statistically significant. Both this baricitinib and tocilizumab are potent immunosuppressant. Therefore, there is potential for an additive risk of infection because patient's immune system becomes suppressed. Therefore, the opportunity infection may come to the patient, which is why antimicrobials may be needed for patients who have bacterial infection. Now, this baricitinib, if tocilizumab is used, baricitinib should not be used. It's either one. Yeah. Next, we move on the anticoagulant used in COVID-19 because COVID-19 itself can cause coagulopathy. The blood becomes thickened and easily becomes clots. If the clots is big enough, it can clog the small veins. If the small veins in the lungs is clogged, then patient may have pulmonary embolism. If the small veins in the brain is clotted, patient can have stroke. If the small vein in the heart clogs, then patient can end up with myocardial infarction. Because this COVID-19 is hypercoagulable state, therefore the risk of thromboembolism disease increase, especially in the clinically ill patients, category 5. But sometimes it can also occur in well patients, especially patients with risk factors, patient in category 3, category 4, but have risk factors such as the VTE risk factors includes the age above 40 years old, patient who previously have prolonged immobility, bedridden, patient who have non-malignancy cancer, or patient have major surgery, multiple trauma, previous history of venous thromboembolism, chronic heart failure, even pregnancy is also included. obesity, and also hormonal replacement therapy. This hormonal replacement therapy can ranges from oral contraceptive or the hormonal depot. Yeah? Pharmacologic prophylaxis, meaning prevention of VTE anticoagulant, is indicated for all hospitalized COVID-19 with high risk factors, while full dose, meaning treatment dose, is used for treatment of VTE. Choices of anticoagulant in COVID-19 includes the low molecular weight heparin such as enoxaparin or tinzaparin is actually the preferred choice. However, unfractioned heparin may also be used in patients with renal impairment or patients with acute kidney injury as well. And fondaparinux is used in individuals with heparin-induced thrombocytopenia, the platelet, low platelet, yeah. Okay, moving on to gastroprotectant used in COVID-19. These drugs is actually not part of the COVID-19 treatment. How in COVID-19 patients. However, if the COVID-19 patients who are more likely to receive these gastroprotectants are patients in the category 5 and category 4 as well. Proton pump inhibitor such as esomeprazole, pantoprazole, and omeprazole is indicated. Is for stress ulcer prophylaxis to prevent patient from getting ulcer bleeding. This PPI is given among patients with risk factors such as those who's been on mechanical ventilation more than 48 hours, patient who have coagulopathy. COVID itself causes coagulopathy. Then high dose steroids. This is also part of the treatment in COVID-19. And then patient who have history of gastric ulcer or GI bleeding in the past 12 months. Patient who have acute liver injury. This can also be present in patient with category 5. Patient who are requiring renal replacement therapy. Also may be present in patient with COVID-19 category 5 as well as patients who with the now, PPI is generally preferred. However, if PPI is not available, other choices such as ranitidine or any other H2 antagonist is an acceptable alternative. This gastroprotectant should be de-escalated when risk factors have resolved or and no longer needed. Okay, we move on our point of interest today, COVID-19 in nutrition interaction. Drug nutrition interaction is defined as alteration of pharmacokinetics or pharmacodynamics of a drug or the nutritional element of a compromise in nutritional status as a result of the addition of a drug. Other definitions, drug nutrition interaction are defined as the interactions which results from the physical, chemical, physiologic or pathophysiologic relationship between a drug and a nutrient or multiple nutrients or food in general or nutritional status. Okay, when drugs, products, and also nutrient or food or nutrition status comes together, have interactions in terms of the pharmaceutical affecting the drug compatibility, solubility, and or stability, and also if there's causing the pharmacokinetic interactions affecting the ADME, A for absorption, D distribution, M metabolism, and E excretion of either the drugs or also nutrients, and affecting also the pharmacodynamic, the effect of a drug, the effect of the nutrients. Eventually, changes in the physiologic outcomes. This interaction may affect the drug of bioavailability, the drug's volume of distribution, clearance of the interaction itself may causes wide derangements of the biomarkers such as changes in the HDL, the LDL level, HDL level, total cholesterol, and etc. And ultimately, this interaction will affect the patient's outcome, be it in the towards the positive outcome, whether the nutrition status improve or the drug effect becomes optimal, or towards the negative outcome, nutritional status becomes worsened, patients malnourished or patients become overfed, or drug effect becomes negative, either toxic effect or the drug itself becomes ineffective. What should we do with this drug nutrition interaction? Now let's recap The treatment for the COVID-19 includes the antiviral, anticoagulant, as well as anti-inflammatory. This is the mainstay of the treatment. For antiviral drug nutrition interaction, previously I've mentioned the use of favipiravir and also remdesivir. Now, these two drugs can cause gastrointestinal symptoms such as diarrhea, nausea, increased gas. For favipiravir itself, it can increases the uric acid, ALT, AST, and blood triglyceride levels. It can also decrease the neutrophil counts. Therefore, nutritional status of the patient should be determined and recommendations should be made to encourage food intake. This is to overcome the patient's GI symptoms. If patient becomes neutropenic, the special nutrition plan should be adopted. As for remdesivir, it can increase the aminotransferase level as well. And then if patient have GI symptoms, then nutritional status should be determined and recommendation should be made to encourage fluid intake. Remember, these two drugs may be given in patient with category 2 or category 3. Yeah? For azithromycin, it is one of the antimicrobials which have drug nutrition interaction, whereas other antimicrobials have minimal to almost insignificant drug nutrition interaction. For azithromycin, this antimicrobial can cause GI symptoms such as nausea, diarrhea, dyspepsia, flatulence, even loss in appetite. Some patients may have altered taste and also abdominal cramps. Therefore, if patient have these gastrointestinal symptoms, diet therapy should be planned and the food intake of the patient should be monitored because we don't want patient to become malnourished, to have low fluid. However, when azithromycin is taken together with food nutrients, the absorption and the bioavailability of azithromycin becomes reduced. Therefore, the azithromycin's concentration in the blood becomes suboptimal, causing the drug becomes maybe ineffective. Therefore, it is advisable to take azithromycin on empty stomach. The bioavailability of this azithromycin also decreases as a result of interaction when taken together with citrus fruits, citrus juices, or carbonated beverages. Therefore, these beverages should not be taken together with azithromycin within 1 to 2 hours. Okay, moving on to anti-inflammatory drug nutrition interaction. This example is ibuprofen and also indomethacin have interaction with the nutrition, whereby the ibuprofen and also indomethacin causes of GI symptoms, dyspepsia, nausea, vomiting. When patients are on either of these medication, patient should be advised to food. Yeah? Then for endomethacin, the absorption is reduced and delayed when taken with food. However, the bioavailability of endomethacin is not affected. Next, anti-inflammatory drug nutrition interaction. In study done by the group, corticosteroid methylprednisolone causes changes in the water, sodium, potassium, calcium, and phosphorus metabolism. Patient can have fluid retention. Patient have hypocalcemia. This corticosteroid also can cause osteoporosis, cardiovascular diseases, impact immune response, and changes in the glucose level. Patient's serum glucose becomes haywire, high. Okay, especially among patients who already have diabetes. And then it also impairs the lipid metabolism, which is why patient who initially have this lipidemia becomes like worsen. Patient who previously does not have an impaired lipid now eventually can have this lipidemia. And then this corticosteroid causes hypokalemia, especially in high doses of corticosteroid, especially patient in category 4 and category 5. Yeah? Okay, therefore, appropriate diet therapy should be planned after thoroughly monitoring these parameters regarding the nutritional interaction. Tocilizumab, which is one of the interleukin inhibitors, it can change in the liver function test and also causes neutropenia. Other than that, tocilizumab also can cause moderate reversible increase in the total cholesterol, LDL, HDL, and the triglyceride levels. Therefore, appropriate diet therapy should be initiated to control the dyslipidemia. And if patient develop neutropenia from the tocilizumab use, a special nutrition plan should be adopted. Gastroprotectant drug nutrition interaction is gastroprotectant, either the PPI, proton pump inhibitor, or the H2 antagonist can be used during the for the COVID-19 in category 5 and category 4 as well. This PPI have been associated with an increased risk of vitamin and mineral deficiencies impacting the vitamin B12, the vitamin C, calcium, iron, and also magnesium metabolism. Therefore, these micronutrients may need some supplementations, especially patients who've been given with this PPI for quite some time. Therefore, the H2 antagonist, it can reduce the stomach acid and is associated with decrease in dietary iron, vitamin B, and also folic acid absorption. Therefore, these micronutrients may need supplementation. And other than that, different administration time is also recommended. And to avoid co-administration between the H2 antagonist together with the iron, vitamin B, and folic acid. Among the ventilated COVID-19 patients, these gastroprotectant drugs, if patient is to be given oral proton pump inhibitors such as the esomeprazole, lansoprazole, pantoprazole, omeprazole, these drugs should be administered 1 hour before or 2 hours after meal or any enteral feeding. This is to maximize the drug absorption. Therefore, if patient is on continuous enteral feeding, the enteral feeding timing may need to be adjusted to allow at least 3 hours gap. Remember, 1 hour before and 2 hours after. So therefore, at least 3 hours gap for the PPI administration to minimize the drug nutrition interaction. Among the ventilated patient also, especially in the patient who are on prone position, meniarap, okay, patient may have GI intolerance where there's enteral aspiration. Therefore, in such cases, adding prokinetic agents such as metoclopramide with or without erythromycin can enhance the GI motility and therefore empty the stomach contents faster. Talking about the patients who recovered from COVID-19, however, these patients may have some sort of complication. If patients have complications such as the thromboembolism, such as the pulmonary embolism, or patient have strokes, direct oral anticoagulant, DOAC, such as dabigatran, rivaroxaban, or apixaban, can prescribe. This is few days before patient discharge or and also during after patient has been discharged. Now, this medication DOAC can be taken with or without food. Although in theory, food and herbal inhibitors or inducers of the cytochrome 3A4 or the P group might interfere with the pharmacokinetics of this medication. However, to this date, there's no direct evidence of such interactions exist. Its other real oral anticoagulant, vitamin K antagonist, the warfarin, if administered in the patient as part of the treatment of pulmonary embolism, it should be administered 1 hour before or 2 hours after meal or enteral feeding. This is to minimize the drug nutrition interaction. Because when administered together, warfarin and nutrient, it can lead to low warfarin levels and eventually will affect the INR reading. So when patient is on warfarin, patient is advised to maintain consistent amount of vitamin K intake. It comes from green leafy vegetables, broccoli, cabbage. Okay, allowing warfarin dose to adjustment to be made in achieving the international normalized ratio INR. Okay, when patient is on warfarin, caffeinated beverage such as the cola, coffee, tea, even the chocolate drinks, and also alcohol can inhibit the warfarin metabolism, causing the INR to be deranged high than supposed. Therefore, taking this caffeinated beverage or alcohol should be avoided. And then since patients who recovered from COVID-19, because patients is given high dose corticosteroid. This high dose corticosteroid usage more than 1 month can result in occurrence of osteonecrosis, has been studied among the SARS patient. Therefore, patient may be discharged with calcium with or without vitamin D supplementation. Or if not given during discharge, patient may be advised to take supplements of these calcium and vitamin D supplements, especially those patients who receive corticosteroid more than 30 days. Now, if patient receives the calcium citrate, this calcium can be taken with or without food. But if patient receive calcium carbonate, then this medication should be taken with food. This is to increase the absorption of the calcium. Now, if vitamin D is given together, the vitamin D helps to increase the calcium absorption, but it can be taken at a different time, with or without food. Okay, we are almost finished. Moving on to the significance of screening for interaction. Screening for interaction is important to minimize nutritional impairment as a result of deficiencies of the energy, protein, electrolytes, or macronutrient deficiencies, or in contrast, overfeeding. Yep. Other than that, we want to sustain the nutrition intake in ensuring nutrition requirements are met. Yeah? So that patient does not become cachectic and also malnourished. Okay. Other than that is to identify necessary monitoring required, especially where it is predicted that certain drugs can cause interaction with the nutrition, nutrition status, such as the tocilizumab, such as the glucocorticosteroids. And then other than that, screening for interaction is also important to predict metabolic complications such as hyperglycemia as a result of the corticosteroid use, electrolyte imbalance as well, overfeeding or malnutrition. Other than that, screening for interaction also important to avoid treatment failure. Remember, azithromycin when combined together with nutrients, it can reduce the absorption and bioavailability, right? Once we know what's the medication which have interaction with food, we can try to tackle the issues to avoid treatment failure as a result of reduced absorption, reduced bioavailability, suboptimal drug concentration, even the accelerated drug clearance and or infective drug. And thus, to ensure optimal treatment is given and also avoid treatment wastage. Kita tak nak membazir lah ya. And then other than that, want to predict adverse drug reaction ranging from GI symptoms, liver biliary abnormalities, such as the use of favipiravir just now. Okay. And then the most important one is to improve the patient outcome. We want to fasten the patient's recovery time, reduce length of stay, and reduce mortality. Okay, so take home messages. COVID-19 interventions are game changing. Therefore, it is important for us to equip ourselves with knowledge so that we can better serve our patients and community. Secondly, screening and tackling drug nutrition interaction is important as it affects the patient's outcome. And lastly, multimodal approach and interdisciplinary collaborations are needed to improve our patient's outcome.